We've all seen this very challenging image at the end of an otherwise successful cataract surgery. Pearls for IOL Exchange will give us some strategies to deal with this very difficult situation. The most effective strategy for salvaging this case is immediately placing the replacement IOL. This protects the posterior capsule and effectively triples the size of the anterior chamber while you're removing the broken IOL. In short, you've created a temporary piggyback. Insert the replacement IOL first. Always use a new snare. Dissect the original IOL slowly. Use OVD for protection and dissection. This sequence will demonstrate the incredible pressure required to cut a silicone IOL with a snare. This snare was not a first-use device. It had been used several times previously unbeknownst to the surgeon, and when the snare was engaged, the force was too great for the snare to tolerate. You'll notice that the surgeon is positioning the IOL to be removed directly over the replacement IOL. And pressure is created, and actually the metal broke rather than the IOL. The dissection of the IOL should be done very carefully. Here we're seeing the breakage of the adhesions of the IOL to the capsule. This lens has been in this eye for approximately 4 months. We're seeing a timeline on the upper left. We're now using viscoelastic to dissect the capsule away from itself, very gently, slowly, and progressively, proceeding in a clockwise fashion. The IOL will now be dissected out of the capsule, which has been released from it, very carefully, and you'll notice that the anterior capsular opening is significantly smaller than the IOL. Gentle manipulation and movement is used to slide the IOL anterior to the anterior capsular opening. The IOL is positioned in the anterior chamber away from the main opening, and the haptic will be removed. Viscoelastic is going to be used to fully inflate the anterior chamber and reposition the IOL within the anterior chamber, protecting the endothelium as well as the posterior capsule when the replacement IOL is inserted underneath the original IOL. This maneuver creates a temporary piggyback with one lens in the capsule and one lens in the anterior chamber. As previously stated, this greatly enhances the safety of the procedure by creating an almost impenetrable barrier between the posterior capsule and the manipulations required in the anterior chamber. The original IOL is now being positioned for dissection with a snare. Viscoelastic is again inserted into the eye to create maximum space. The snare is checked to make sure it's fully functional and appropriately positioned. The snare is now positioned over the original IOL, and the original IOL and snare joined together are positioned carefully anterior to the replacement IOL to protect the posterior capsule. The IOL is now readily removed from the anterior chamber. The eye has been previously fully inflated with retentive viscoelastic. It is a great challenge to remove it all from the eye and requires vigorous irrigation aspiration as well as manipulation of the IOL. You will notice how strong the capsule remains and how well it's been dissected, even though it's approximately 4 months after its original insertion. You will notice also superior temporally that there is significant scarring around the previous position of the haptic. In spite of this, the original IOL was readily dissected from the capsule. Irrigation is now going to be used to remove further viscoelastic from the capsule itself. And the anterior chamber. The IOL is purposely being vigorously manipulated to maximize removal of the viscoelastic. To review the 4 pearls, we insert the replacement IOL first. We always use a new snare. We're very careful about dissecting slowly and persistently to release the prior adhesions. We use OVD for protection as well as dissection. Again, persistently, but slowly. Hopefully these pearls will take you from the before to the after, every time.